Thank you all three for joining me today. Maybe we could start by you introducing yourselves just briefly. We'll just start there.
Great. I'm Tracy Proud. I'm an associate professor of psychology at the Furkhoff Graduate School, and I teach in the school clinical child combined program, and I co-lead the psychodynamic practicum with the illustrious Jordan Bate.
That's me. I'm Jordan. I am an assistant professor in the combined school clinical child psychology program at Furkhoff Graduate School of Psychology at Yeshiva. And I am also a voluntary supervising psychologist at Lenox Hill.
There you go. I'm Katie Afius Van Doorn. I'm in the hallway next door. Usually without a pandemic, that would be the case. So I'm in the adult clinical program, and I'm an assistant professor there. And I teach evidence-based psychodynamic therapy. So that's my angle. And I guess how just want to jump in to say how we got excited about this whole deliberate practice thing. Because that was really such a collaboration with the three of us. Some inspiration from the Society of Psychotherapy Research Conference in Amsterdam 2 years ago, I think. That afterwards I was mulling over, like, what can we do with this deliberate practice? And I'm thinking about how we should tackle the psychodynamic teaching within our department, and I'm not really sure how we could improve it. And I'm thinking, well, actually, maybe deliberate practice is something that would be so useful in advancing our students' skills and the internal skills of just noticing feelings and being more aware of what's going on when you sit with a patient, as well as the interpersonal skills that we then later on added to our thinking too. But I guess it all started off with just a lot of excitement after a conference and me emailing Tracy, like, there's something here, we should do something, we should see if we can maybe set something up at Furkhoff. And then Jordan Bate was just joining the team as well that year. So I think you just sort of excitedly added a lot of contributions too. So it was really a team effort.
Well, that was also this interesting intersection for me as well, because I did my graduate training at the New School and with Jeremy Safran. And so then after his death, I was collaborating with some of his students on his research that he had started in training that's all focused on experiential kinds of training and bringing that to hospital settings. And so I was hearing from the New School students, they were talking about deliberate practice. And then I got to Furkhoff, and Tracy said she and Katie had this idea around deliberate practice. And it's a nice
perfect synergy.
Yeah.
Great. I mean, thank you all for joining me today. As far as I know, you guys are at the forefront, the cutting edge of experimenting with implementing deliberate practice. I don't know of any training program that's done as much or more, definitely not more than you guys have done. So, and we get questions all the time, like, how do we do this? What's going to work? What's not going to work? That kind of thing. And so if you guys could just share briefly, like, what you've tried, and then we can get into what your experiences have been.
Sure. You want me to talk about that a little bit? Okay. What have we tried? We've learned a lot about what works, what doesn't. So we've been doing this for 2 years in our psychodynamic training in the child program. And what we've done so far is split it up into 2 semesters. It's a year-long training sequence. And so in the first semester, the students read your book, and they do the deliberate practice exercises each week. I think what we have it set up is they do the 6 exercises, and then they repeat them. They do them twice.
So they do exercise 1 for 2 weeks in a row, exercise 2 for 2 weeks in a row.
Thank you. I'm not so good on details. And they start out because they're just starting with their patients then. So at that point, they watch the sort of video stimuli from the list that you created, Tony, and we've modified that list a little bit to be more child focused. So we've added, other YouTube videos, other clips from different websites that are either child focused or parent focused, because we also do a lot of parent work. And then as they ramp up and are seeing their own patients in the clinic, we do have video recording capabilities in our clinic. And the students take those videos of their clinical work to supervision every week, and they show them in class for their case presentations. So I think we're lucky to have that available. I know that's one of the challenges sometimes for people. And so then we encourage them to do the exercises with regard to difficult moments in their own clinical work. And so each week they do the exercise and they complete the reaction form. We have it set up online. So we're collecting that data on Qualtrics. The questions about, how difficult, how helpful, what sorts of reactions did you notice? And for the reactions part, they're checking off what types of reactions they felt, whether they were emotional or cognitive, physiological urges they had to do something. And then we also collect narrative data. So we have them write out exactly what they noticed. So that's pretty much the first semester. Do you guys want to add anything to the first semester overview?
I guess I just want to put it into a context of, I guess we're also researchers, so we're very keen to understand what helps and what doesn't help. So before they start with any of the exercises, we ask them to complete measures on affect tolerance, on experiential avoidance, on mindfulness, reflective functioning, just to have a baseline. And then at the end of the first semester, they do these measures again, and then again at the end of the second semester. So you just track progress over time.
And we only have about 20 students at a time. So we so far have 2 years of data collection. So that's only 40 students. So we're trying to, get some kind of critical mass and then really look at some of that data. Go ahead, Tony.
And this is starting with first year students, like right out of the gate, right?
No, our students are all 3rd and 4th year students.
Okay.
So in their first year, they do all coursework. In their second year, they do an externship in a school setting where it's not a lot of psychotherapy. There's some counseling, there's some assessment and testing. So this is for the 3rd years, their first real clinical experience, unless they came into the program with, a master's or something.
Right. Although I think it's really interesting to think about training trajectory and how we also, as professors and as a program and in this field, start to prepare students to learn and train in this way. So this last year was my first year teaching a class to the second years, which is one of their first clinical classes on beginning work with children, parents, and families. And so even though I didn't assign them any deliberate practice and they're not yet seeing therapy patients in a clinic, I did in class a number of different experiential exercises where we watched video clips and they paid attention to like what they were feeling and things and their reactions, and really trying to do kind of a group deliberate practice before they're even at that point in their training, which, I also have this experience doing some training at Lenox Hill, and I think I've realized the importance of kind of preparing students for learning in this way, because it is like a different way of learning and practicing. And so I think we can like start to prepare students that this is in addition to your supervision and your coursework, watching videos and thinking about material in this way is part of your training as well.
Yeah, and I know in the adult clinical program, that's the same. In the even in the very first year, they get exposed to deliberate practice, although it's not as full of practicum as we're talking about today, but they definitely have heard about it and practiced a little bit with it. So it's hopefully everyone will be exposed to it.
Yeah. And we also try and model that as professors when we're supervising, sort of noticing in the moment, what we're experiencing, and, also being very transparent in the same way that you are, Tony, about all the mistakes that we make as therapists, how much we all have to learn.
Flush
Um,
mistakes.
what's that?
Tony's phrase for it, flushing out the mistakes.
Yeah, yeah.
Great. And in that first semester, we're really focusing a lot on intrapersonal experience and training.
Okay.
Yeah. And so one of the things we also do is we have them fill out each week the countertransference questionnaire. And so that is looking at, we ask them to report on their most difficult session of the week. And that could be in our clinic, it could be at their externship, it could even be a missed session, what came up for them when the patient note code. And so we're collecting that also. And I think one of the challenges we faced in the first time we did this first semester piece was, we were new to deliberate practice and didn't quite know how to then translate it into the classroom. Like they were doing all these exercises and doing the homework, and we were also doing exercises on our own. And so this last year, we asked you if you would help us out, and having you do some live supervision with our students, I think was so helpful. I know to me, and I'm sure to Jordan too, of just learning, like, how do we then implement it live in the classroom and not just make it an out of class experience.
And so what did you learn there? Because I remember some of the students responded well, and some of the students were like, I have no idea what's going on. So
yeah,
what did you learn?
I can talk about this a little bit because I also feel like I think we did it in my class first. So like we would do it in my class, for Tracy's class. Maybe this is how it should get modified. I think, so if I'm remembering accurately, the first week that we did it, so the students had the experience of having a week with Tony in our class and a week without, for people listening. So the first week that we did it was, I think, most similar to doing an individual deliberate practice, but in the context of the group and with the group there. And I remember the student who showed her video, I remember that this really stayed with me as something that I think is helpful for deliberate practice. She was able to watch her video and very quickly pick up, that's where I was misattuned. Like that's where I said a word for the patient's feeling that's not what the patient was feeling. And that to me stood out as like something that's really valuable for students to learn to be able to do, and that I learned over the course of the semester. Like we aren't all kind of that good at picking out like, this is the problem that I'm having, or like right there is the moment I had the problem. Often I think we come in feeling like I had a hard time in this session, or I'm struggling with my frustration with this parent. We come in with like a general feeling of like, I'm struggling with my countertransference. But what this student did was like picked up like right there in that moment, I, used the wrong word to empathize, and it's not really right what I said. And then I remember you did a couple of things, Tony. First, she watched her video looking at her patient. And then that, when we checked in about how challenging that was actually like quite arousing in terms of her, her anxiety. And so then you put a Post-it over the patient's face. And I remember like thinking that, like, that was something I learned that was like, oh, that's like such a good idea. Like, don't just stop watching the stimuli and switch to a YouTube video. Like, keep the stimuli there, but cover the most affectively charged face. And then you had her, I think, say to the, one of the things she clarified was that, she was really struggling with the strong emotions it was bringing up in her. And you suggested that, not as an intervention, but you just say to the patient, say to the video, what she was experiencing in the moment and the feelings that were coming up. And I remember there being a moment where I felt like I could hear the emotion in her voice. And And I remember thinking like, this is like amazing. Like you could hear the shift where like she was starting to like feel the emotion, and it was like really present in a way that I think what, like I just presented on deliberate practice to a group at Lenox Hill yesterday, and they were like, I showed the video of you repeating over and over, and they were like, it looks, it does, you feel like you're gonna look silly or foolish. But I think the experience of seeing that like her doing this like did not look silly or foolish at all. It was like really emotionally powerful. And in fact, I think that was one of the harder things in the group, is like thinking about like some of this can be really emotionally powerful, and what you're going to do in a group, because I think it was this really powerful moment we were all witnessing. And in some sense, like, I'm not sure I was like, even as the professor, I like won't even talk about the students, but like, you kind of have to be prepared to like bear witness, because it's not the same kind of supervision of like, we're going back and forth and we're, talking about conceptualizing the patient. Like we're really there with the person who's doing it, having this, emotional experience and trying to support them. And I think over the course of the semester, then we tried different things. So then we moved to, instead of having it be one person, we had one person bring their patient and talk about what they were having trouble with. And then we created role play exercises that people could do in small groups. So it wasn't that feeling of us all participating in one person's deliberate practice. And I think that then that had I know there are some good examples from Tracy's group as well, but I think the students really felt like getting to hear what someone else would say, and not just hear it, because that happens in class all the time. We're always saying to each other, oh, have you thought about saying this, or why don't you try, but actually like trying on another person's words. And I remember noticing in that when I was going around, they would start with saying whatever sort of suggested response I think I had given. And then, but then their own creativity would get freed up in doing that. So they would start by saying what I said, but then like all of a sudden, a lot more ideas would come to people's minds, much more than I think comes to your mind when a person just presents their patient and then you say, so what do people think? Everybody.
And I guess I'm just thinking about your comment, Jordan, about the comparison with supervision, for example. But I think one of the crucial sort of assumptions or rules that you need to agree before this is that it's not an evaluation, right? That the fact that they participate is what you evaluate them, that they need to engage. But whether they say something that may sound stupid, or they don't have to pretend to be clever or know it all, right? That would actually be counter-effective. So I guess that just needs to be so clear. Whereas I think a lot of situations, students need to or want to please their supervisor and show this fantastic little bit of tape that shows that they really know what they're doing. Or whereas this is actually the other way around. Really, it's the more vulnerable you are, the better you can make use of this time.
Yeah, and we say that explicitly at the beginning of the semester. I think one of the challenges or things that was difficult for students were students who were like, yeah, this is great, but I want my traditional supervision where we do case conceptualization and you tell me like what to do.
Yeah.
And I mean, I get it. I, as a former student, I remember feeling that too. So trying to find that balance is a challenge. And I think, it's different for every cohort and every professor and every supervisor. The other thing that Jordan sort of...
One more on that very quickly, because I think a big part of it is not going into the case conceptualization, because one of the deliberate practice exercises that we did in the classroom, and then we haven't talked yet about the way we use TheraView for deliberate practice in the second half of the year, but they are actually like sort of being told what to say or what skill to practice and what to do. But then they want to be like, well, why would you say that?
Yeah, like, the theory.
How did you come up with that? And it's like, that's not what we're practicing right now. So just wanted to, I think the not having the conceptualization part and it gets can get us really derailed. Like I got derailed many times in class, like then explaining like how I came up with that response.
Right.
And actually deliberate practice, we want to just be practicing that response.
Right.
Yeah, and I think what Jordan mentioned earlier is a challenge of how vulnerable it can be. And I know the first time you supervised in my class, Tony, I had this wonderful student who I know really well, and he had no idea what to expect, but he was so engaged, and it was really transformative. And knowing like additional things about his life and, just who he is as a person, I was watching it unfold and thinking, wow, this is not just about his clinical work. This is about like him as a person.
Yeah, sure.
And he loved it, and he felt really moved and encouraged by it. But I think for some students watching it,
It's intense.
there's kind of parallel process of like, I can't tolerate affect in the room with my patient. I also can't tolerate watching this thing happen to my friend.
Yeah.
And so, we talked about that in class with the students. And I think that was actually a really, really valuable conversation.
And so
Yeah, I was going to ask if you want me to say anything about the TheraView piece, or you're going to ask something else.
Yeah, first about if that's like really important, but first, if you could clarify how you help trainees maintain boundaries, especially for the intrapersonal work, because it's so personal, right? So what work there? What's your advice?
I really liked it was really helpful for me to watch you, Tony, because you are always checking in. You're like, if this is uncomfortable, if this feels like too much, you're always, how difficult is this? Okay, let's dial it back a little bit. And you really, I think we talked also maybe midway through the semester about kind of setting a little more of a frame around, look, you only do what feels comfortable, and you don't have to do more than that. Like Katie said, you just have to show up. Like there's no like threshold that you need to cross, like intimacy and vulnerability. So I think that constant checking in is really important and really helpful.
Yeah.
And affirming, there was a couple of students who were like, this is too much. And I was very affirming of that. Like,
Right.
that is a super important point.
Right.
And, it shouldn't feel like too much. It should feel like just right.
Yeah.
Let's think about how we can modify.
I think also, like this isn't the time to like cold call on people or try to like make people verbally. That also like recognizing that like a lot of this work, like what's most important is that the person is doing it in their own head and their own, and it's not so much about whether they say it out loud to us. And I think when you did it in our class, you often said like, you don't have to say out loud what you felt, just know yourself what you felt. I think that really helps. I think having on one of the worksheets that we use to guide how challenging or how useful the exercises are, there's one version of that has like words that you might have felt on it, which I think like being able to see like, oh, okay, that thing I was feeling, that's like normal and expected. I think that really helps. And like setting aside time to process. Like I know we also talked a lot about like where we did it in the class time and like how and in at least in my section this year, I think it worked best to do it at the beginning, get right into it, and then process after, like how was that to do, and then get into like questions about, so how did I come up with the suggested response, and get into the theoretical questions to kind of help people also like get back on their feet before leaving.
And we also let people sign up for those times when you were supervising. So you didn't have to do live deliberate practice with Tony in front of your whole class.
Voluntary.
It was like, if you want to, it's a great opportunity, but no pressure.
And what did you guys find with the homework? How did the students respond to doing the homework?
I think they really liked it. I think at first they were a little disoriented.
Yeah.
Unlike anything they've done before. But I remember from our our the first semester of data, I think they did 257 exercises.
Yeah, we did the calculations of how many minutes they would have spent on deliberate practice, right?
Wow.
Yeah.
Yeah. So among the 20 of them, they did a lot of exercises.
Wow.
So they were doing them, and they would say, oh yeah, that one was tough, or they would write in the narrative like, I picked a video that was a little too easy. I'm gonna try something different next week, or like, that was so overwhelming, I hope I never have to see that again.
Yeah.
I think an area I'm hoping to grow in as a supervisor in this is to figure out how to help students personalize their homework.
Yeah.
Especially I guess throughout the year. I was going to say, especially at the beginning of the year when I don't really know them that well. So we really give them a lot of kind of independence in terms of what they choose to do. Like, we don't say, you might like work on this, or you might try these kinds of clips. They're really deciding what they do in the homework on their own, at least in the first half. In TheraView, they're assigned modules. But I think that that's something where I remember actually hearing Hannah Levinson talk about you working with one of her students and giving her student a really like kind of personalized kind of exercise to do for homework, to really address what she was experiencing in the session. And I think that's something that like I'm hoping to be able to grow in as a supervisor, and something that I think is hard in the classroom. Like when you have a class of 10 students that you're going to over the whole year, like it also like feels like a goal that's not totally achievable, but like I'm going to be able to say like, oh, Tracy, like you might try this, or like I'm not going to get to know them really well, but their individual supervisors are actually the people who are really to help them do that. And I think is something for us, like in our practicum, and it would be my suggestion to anybody doing this, is to like think about how do you kind of create a sort of ethos around deliberate practice, so that individual supervisors can help their supervisees figure out what to do during those.
Great. Could you describe what you did with TheraView and how that went?
Sure. So in the second semester, we use a platform called TheraView, which is sort of curated brief videos of actors portraying moments in psychotherapy. And you can group them into modules, which is what we do. So there are modules, for example, for confrontation, where a patient is like, what are you even doing? I'm tired of this. Or modules for practicing empathic responding, or dealing with issues of difference, whether it be culture or sexual identity, dealing with termination. And so each week they have 3 videos that they watch. And the way that TheraView is designed is that then after they watch the clip, they then video record themselves on the platform as they would respond if they were the therapist in that moment. And the students can re-record as many times as they want, which is a nice kind of built-in practicing and rewatch.
Yeah, that's crucial, I think. That's crucial. It doesn't have to be perfect,
Yeah, and then they grade themselves with a rubric. Was I defensive? Did I leave room for the patient to elaborate? Something like that. And then we watch the clips and provide feedback, written feedback through the platform. And maybe Katie or Jordan want to weigh in on this. I think it's intimidating at the beginning. The students are terrified. They really like it once they get into it. It's a lot of work for us to watch 30 videos a week, and provide written feedback. And the options for videos, and this is true, I think, for all deliberate practice options, are a little bit limited for child and adolescent. There just aren't a lot of videos. And so Jordan created some videos. Yay, Jordan. And the research component of the second semester is that we have a special course on TheraView where they're not able to re-record. So they, at the beginning of the second semester, watch 3 videos and respond. Just one shot, good luck. And those videos are saved. And then we do that again at the end of the semester, 3 videos, no chance to re-record. And those videos, sort of a pre and post test, are being coded for facilitative interpersonal skills, Tim Anderson's kind of framework for interpersonal skills. So that's the research component of that.
Great.
And then of course they still continue with the other measures also. So it's
every week
a lot of evaluation in that sense. So we still have to.
Sorry, Katie. They're doing the same deliberate practice form, how difficult, how helpful, all the reactions they noticed, and the countertransference questionnaire.
Exactly, and the pre and post before and at the end of the semester, the affect tolerance and experiential avoidance and mindfulness and reflective functioning skills. So we set it all up on Qualtrics, so they don't have to, it's in that sense quite straightforward. But there are just a lot of different aspects to this whole practicum for the students, for sure.
I think one thing that's different, so Tracy talked a little bit about us reviewing the clips and giving them feedback. And I think that's something that we don't have a way that we do that for the individual deliberate practice that they do in the first semester. And I don't know what it would be for those kinds of exercises, but I do think that there's actually something really meaningful about them knowing that we watch it, and like many students have written to me saying like, thank you so much for the comments that you made in watching my videos. Those were like immensely helpful. And I haven't figured out like what kind of feedback component we could do in the first semester with the the intrapsychic deliberate practice exercises, because I actually think being seen and having the feedback is very motivating for them.
Yeah, that's a good point.
Yeah. But with regards to safety or the vulnerability, I think it is not a bad sort of stepping stone that first you try yourself and you have this internal experience, and then only in the next semester that you actually practice with interpersonal skills and how you come across, and then you record it. And so it's hopefully the students by the end of the second semester will be really confident in at least in trying this out in these experiential exercises.
Yeah, Jordan, do you want to say something about the feedback from students about the order?
Yeah. And I think it's an open question. So students responded to feedback about the class and specifically deliberate practice, saying they would find it helpful to do it in the other order. They would prefer to start with responding to TheraView or TheraView-like videos, but to have the focus be on what to say
to the client.
Yeah. And then
developmentally, we think it makes sense the other way. I think
exactly.
Yeah, and I think it's also in a way we just have to test this out. We just have to see what does actually work, because I can't help but think to myself, yeah, I know you would have liked to have gotten this earlier, but actually if you hadn't gotten that internal work first, would the experience of doing those videos, like Katie's saying, be different? Because really they are building the interpersonal skills on top of the intrapsychic skills. By the time they get to TheraView, they're doing TheraView, but they are also filling out the form about how they felt doing it. They're really like putting two things together, able to to do, I think, practice more complex interpersonal skills like meta communication and rupture repair when they've already had the practice being aware of themselves and their bodies. But
and for the second year, we did not respond to their request to change it because we wanted to keep our research protocol the same. You don't want to mess with the protocol while you're trying to collect data. So I think Jordan, I'm on sabbatical in the fall, so Jordan is the boss lady of all our things. So I think she's making some changes to that. So
yeah,
we'll see.
what I'm going to try out for next year, or at least what my current plan is, I think with deliberate practice, you have to be a little flexible too.
Yeah.
So my plan is that actually, I think I just have them doing deliberate practice exercises for like the first 6 weeks. So instead of a whole semester, they do the intra-psychic deliberate practice skills. So for those who are not as familiar, those are the practice exercises where you'd like watch a YouTube clip and pay attention to your thoughts and feelings and urges. So they'll do that instead of for the full first semester. They'll do it for the first half of the first semester. And then they'll do the second half of the first semester and the second half of second half of the first semester and first half of the second semester. So the middle half of the course, they will do TheraView with the sort of modules that we already had. So where they're in some ways prompted, like you're about to see a clip about determination and you need to address that, or you're supposed to use empathy in this response. So they'll do the modules for TheraView. And then the last quarter of the course, they will do TheraView, but without any like topic assigned. So, and they will be asked to provide a response, but also do intra-psychic deliberate with it as well. So my hope in making that revision is that, so then they'll get the sort of internal work, then the interpersonal, but without sort of the pressure of having to put it all together. And then they'll actually get some practice, because I think students also, there's a question of like, how do you decide what you're going to do in the moment? I think this like connects to Bill Stiles' work on responsiveness.
Responsiveness, yeah.
Yeah, that there is also, there's some internal process we do as clinicians where we, think about all we have in our minds, the theory, our supervisors, things our therapist has said to us, and what we're feeling with the patient, and we somehow put it together and say something back to the patient. And that the way TheraView is right now in our course, they weren't really having to do as much of that, putting it together. So that will be like the last piece.
Kind of like a clinical decision making or something like that, kind of.
Yeah. And also doing some deliberate practice around like reflecting on their own responsiveness.
Right. Are there any, based on your experiences, are there any things that just went really poorly, like kind of red flags you'd really warn people about, anything like that?
None that come.
I jotted down.
I guess what I'm thinking about now is that all three of us are psychodynamically oriented, and that's, I guess, the angle that we took, and for me, deliberate practice fits so well with psychodynamic theories and relational theories, and but it doesn't have to be. And I guess my hope is that across the different programs, the different modalities that people want to learn, that this becomes standard practice for just therapy skills in general. It doesn't have to be specific for a modality. So I guess we've been presenting towards or about what we've been doing to other people in the faculty team, and I know that in team meetings, it comes up in discussions, and I know different courses are integrating it slightly. So hopefully it will just be part and parcel of psychotherapy training. And I guess I don't want to people to forget that it's not necessarily only psychodynamic. It fits well, but I think CBT clinicians or other integrative therapists could definitely benefit from this also.
Great.
And I think on the flip side of that, the one challenge I have found, not at all with our students or our implementation, is actually my experience that many psychoanalytic clinicians are quite resistant to this kind of approach. I think they worry that it's robotic, or it's ignoring, 100 years of very rich, meaningful psychoanalytic theory, or that we're becoming like automatons or something. But I think when you see it done and you do it yourself, you see that it's not that at all. It's just another way, and maybe a little bit more structured way to get at the same things that every good psychodynamic supervisor wants to get at. Who is the therapist as person? What aspects of your reaction to patients is subjective? What parts are objective and could be useful clinically? Is got so much to offer. But so that maybe is one little landmine people could step on.
Actually, that made me think of something, an exercise I did in my class last year, where because there's also, in TheraView at least, doing that kind of a deliberate practice it's very verbally focused. And I think actually the deliberate practice exercises in your book are certainly, very non-verbally focused.
Internally, yeah.
Yeah, they're internally focused. And so one exercise I did in my psychodynamic practicum class was to have students do a silent role play. So instead of role playing, this is what my patient said, I had students play their own patient. And these are child patients, so much of it is physical space. So they role played their own child patient, but they had to be silent and just role play what their patient's body was like, what their patient's was like. And then I told the person playing the therapist had to try to kind of collaborate and join and connect non-verbally. And when they did that, I remember one student said he was playing a patient with ADHD, and I asked him how it felt in his body to play that patient. He said, like, really free. And it was like, what a wonderful way to be able to connect with his patient's experience in a way that you wouldn't if you just think in terms of ADHD and lack of focus and hyperactivity. And similarly, then the students got feedback from the person playing the therapist about how hard it was to connect, or what it felt like to be them. And I think that's really validating. I think it's something we are always trying to do in supervision, group and individual, is kind of validate how hard this work is to do. And so I think a challenge, I guess, that I tried to solve was, I think a challenge is you can kind of pick up these books or start doing this and feel really get sort of stuck. And I think one of the great things about our conversations with you and also doing this as a team, not being just one person teaching the practicum, is being able to talk about other ideas and think okay, we've been doing a lot of verbal, we're addressing that a lot, but we're not thinking about the nonverbal part of the work, and then creating new exercises that do that within the same framework of deliberate practice.
Another challenge just came to mind, which is that if you're adding in deliberate practice, you're taking up time.
Yeah.
And particularly in child work, there's so many safety issues and liability issues.
Case management kind of stuff.
Yeah. And so just kind of managing how to do all the things in a 2-hour course each week. Just, you figure it out.
Yeah. Great. I mean, we can start wrapping up. Any last advice for a supervisor, professor who might be curious, just wants to dip their toe in, just kind of try it out? Or how would you recommend starting?
I think you have to start by doing it yourself. I think you have to see what it feels like to like even 30 minutes is a long time to do deliberate practice. Like we're all very busy. Even when everything's on Zoom, it still feels like it's one thing after another. And so I think you do, like one thing you have to do is you have to try taking time out of your week, 15 to 30 minutes to do this kind of work. And I think one thing that really stuck with our students is when Tracy and I have shared our experiences doing it. And including we record our own therapy videos.
Oh, wow,
Yeah.
cool.
Back from us. They also get to watch ours.
Oh, that's great.
So I think
showing your mistakes, right? I think that's almost like the best learning for students, rather than trying to be this perfect therapist. But no, just trial and error, and you do something and actually no, you want to do something different afterwards, and amend and adjust and attune, and it's a lifelong process. And I think that's a message that it's not just for trainees, it's for everyone, it's for all of us. So it's hopefully it's a lesson that the students internalize and that they can build on themselves later on.
I wonder if we have time, Tony, if I could read a couple quotes from students.
Oh, that'd be great. Yeah, that'd be wonderful.
About their experience. So here's a student talking about the overall response to a year of deliberate practice. This was really useful in terms of helping me become more aware of how I present as a clinician, in terms of becoming more aware of my body language, my limitations, my areas of discomfort. And one other quote from a student who was watching one of their own videos, one of their own therapy videos, and doing deliberate practice with that stimulus. This person wrote, "During my patient's hesitations, I felt anxious and nervous. I appear relaxed in the video, but my heartbeat was increasing and my thoughts were racing through my head. I remember thinking, oh crap, I gotta do something. I had the urge to say certain things, which I did not say. I'm not sure what emotion I was feeling, but maybe embarrassed or incompetent." And then one last quote. "All of this helped me confront issues that I have not yet encountered in my own therapy cases. It also allowed me to have a more worry-free experience in dealing with these situations without fear." And I thought, there's nothing more you could ask for.
All of those speak to what you were saying earlier about it's the opposite of like trainees turning into robots. They're really having deep, very personal experiences of self-reflection and growth.
And even sorry. No, I was just thinking about the feeling word checklist that we used for as measure of countertransference. And so what we have seen is that over time, people report a wider range of different feelings, which I think is one of the best results that you can really have, is that they're so more tuned with all the different types of experience that they can have when they sit with a patient and when they practice these kind of experiences.
Oh, wow.
Feel more comfortable reporting it.
Right.
Anybody who worries about students becoming like more robotic and just doing things that they've learned and trying to memorize and make them rote, I think really like what this does is like it gives the students opportunities to like practice being on their feet and thinking on their feet and in some way. And I often like sort of joke like a workout video, like get comfortable being uncomfortable, or like now my sort of latest way of thinking about it is like there's a kind of practiced flexibility, I think, in responding that like you don't actually get more rote. Although some students do that. Like some students, I'll say, you gave 3 very similar responses this week, or I've been noticing that your responses always start with this, I hear, and, use this opportunity. So I think it also gives us an opportunity to actually see if students are doing things too automatically, getting stuck in patterns and not being, flexible and creative. That's an opportunity to point that out in a way that's also a lot easier to point out than when you watch someone's therapy video. Like it's
Right.
because I'm still relatively junior when it comes to being a supervisor. But, you know, most of the time I watch someone's video of their session and I'm like, I mean, you did well, like this is hard work, and, you know, I can add some suggestions and thoughts, but like, I'm really hesitant to ever kind of be critical of someone's, you know, therapy video, as long as they're really trying. And I think actually being able to respond, you know, give them feedback on something that is removed. Sorry, my background noise right now.
It's okay.
Feedback on something that you can cut that out.
Yeah, no, but that's true. It's specific. It's focused, right? And that's what's so helpful in providing the feedback.
And one step removed from like the really vulnerable work, which is like our, you know, what we're actually doing in the session.
Great. So it facilitates, creates an environment for constructive feedback that can even guard against a robotic response to therapy.
Yeah, I think one thing that could strengthen our program is if we could figure out how to train all of or disseminate this to all of our individual supervisors. It's hard to get them all en masse, you know, even if it's on Zoom, but that's definitely something that we're thinking about.
Great. I think we should wrap it up here. We've gone about an hour. I just want to thank you all for sharing your experiences. You know, there's very few programs are doing what you're doing, which is really diving in and experimenting with these different types of delivery practice, and then kind of assessing, collecting all this data. I'm really excited to see, you know, your publications, what comes out of this. And I think other supervisors, professors will learn a lot from your experiences. So I'd love to, you know, have you on again in a year or two and get an update.
Thank you so much, Tony.
Sounds good.
Yeah.
Cool. Well, thanks
you.
all, and I guess I'd say goodbye.
Okay. Bye, everyone.
Bye.
Bye.